My name is Victor Urrutia. I'm Associate Professor of Neurology and Director of the Comprehensive Stroke Center at Johns Hopkins Hospital in Baltimore, Maryland. And I am going to talk about pre-hospital care of stroke and EMS routing. So in the last 23 years, the acute treatment of stroke has had great advancements from the original NIMS trial, in which they demonstrated that IV thrombolytic therapy with alteplase was effective in treatment of acute stroke and improved outcomes at 3 months. The drug was approved by the FDA in the US in 1996, and in 2008, the ECAS-3 trial demonstrated that the thrombolytic therapy IV could be used up to 4.5 hours. And in 2015, we had a series of clinical trials that demonstrated that endovascular therapy, specifically mechanical thrombectomy, was effective for acute stroke up to 6 hours. And then in 2017 and subsequently 2018, the DAWN and DIFFUSE-3 trials demonstrated the ability to select patients with large audio occlusion using perfusion imaging to treat them up to 24 hours from last known well. Now, these advancements have been great for expanding the treatment of acute stroke. However, they do require a significant amount of organization. And from the days of IVTPA, emergency departments, stroke services needed to be organized from the pre-hospital setting to the emergency to the hospital setting to be able to identify, transport, screen, and treat patients that were appropriate for treatment in a very rapid manner, being that there was a 3-hour time window and patients needed to be evaluated quickly to determine suitability for treatment. Now, you may think that with the 24-hour window, that may have gone away, but the reality is that our ability to treat patients to 24 hours, while it's great, still requires quick detection and selection of the patients, because for the individual patient, there is definitely damage that is occurring over time. And one of the things that have become evident is that the time that it takes to get a patient, specifically the patients that have large audio occlusion that need to be treated at specific centers, is a big determinant of the ability of the patient to get benefit from the treatment. So we currently have 2 epochs or 2 time windows that we have to consider a little bit different. In the 0 to 4.5 hours, patients can be treated with IV alteplase, so IV thrombolytic therapy, and those that have large audio occlusion can be treated with mechanical thrombectomy. So in this window, effectively, we're going to be treating all strokes that we know their time of last known well, and that are up to 4.5 hours, and the patients can be treated with a CT scan, non-contrast, for selection, or if they have signs and symptoms of large vessel occlusion, CT angiogram is necessary to assess that and then guide them towards the thrombectomy. In the 4.5 to 24 hours, what we're going to be able to treat are patients with large audio occlusion, and the patients that have small vessel occlusion are not amenable to treatment, and currently there's no evidence-based indication for thrombolytic therapy in this window. Patients that have large vessel occlusion need to be detected, and they will need CT scan, non-contrast, CT angiogram, and CT perfusion imaging to be able to determine if they can be selected for treatment. Depending on the protocol that one uses, one could select patients with CT perfusion and CT angiogram, or with MRI and MRI perfusion and MRA. This has become a recognized issue. For example, in the United States, you can see the two maps that I'm showing in the screen. And the top part is the coverage for patients to get to a center where they can receive IV thrombolytic therapy for acute stroke within 60 minutes is the gray areas. And you can see that there are vast areas of the US that are uncovered, in which a patient does not have access to a hospital that can treat them with IV thrombolytic therapy within an hour of onset. In the lower map, we can see that there are even greater areas where patients don't have access to endovascular therapy, to mechanical thrombectomy via ambulance or helicopter within 60 minutes. And this is a significant issue because the benefit of thrombectomy for a patient with large arterial occlusion is great since the numbers needed to treat to get one patient to benefit is on average 4, which is a significant efficacy for treatment in an acute stroke or any acute disease. So there's been several approaches that we have thought about, and one is to expand the number of centers that can do thrombectomy, for example. And in this two maps of California, and in the map on the left-hand side of the screen shows a greater coverage if you take every hospital that is able to do thrombectomy and regardless of the number of thrombectomies that they do per year. In the right-hand side, you have a map that shows more gaps in coverage because we're taking then centers that are able to do thrombectomy, but that have completed more than 10 cases in the last year. So that creates an issue. There's no question that by doing more cases, centers become more proficient and the outcomes are better, but it does create an issue with access. So right now, the strategy that has been more prevalent is to try to increase access by other means, but still concentrating the expertise in centers that are able to do many of these cases. So here are the issues with the logistics: access versus expertise, which I mentioned. We want patients to go to high volume centers where they can get treatment by experts. So we need more centers. And one of the things that have happened in the US is that at the beginning we had the primary stroke centers and the comprehensive stroke centers, which would be, the latter would be the higher end, more complex centers. Classification of a thrombectomy stroke center was created in between so that hospitals that were able to keep up their volumes and expertise for thrombectomy could do it without needing to invest in the expert treatment of other cerebrovascular diseases. The ability of using telestroke, either by telephone teleradiology versus video, has also added access to the expertise. So where you can treat patients with TPA at a distance. And air transport is actually very important. And the transport will be a helicopter, especially for distant areas, have become more common in the treatment of acute stroke based on the recognition of the need for speed in treatment. Now, in terms of the speed of treatment, there's a lot of discussions, and there's been a lot of projects, and I will discuss what we've done in Maryland, of taking the right patient to the right center. So the pre-hospital screening and rerouting of ambulances to hospitals that can actually do the thrombectomy, as opposed to taking them to a hospital that is not able to do it and then transferring as a secondary transfer to the hospital that is able to do the procedure. The first approach tends to be faster, and there's been a lot of work in trying to develop that. The door in, door out concept as a performance measure basically measures the time that it takes a patient that arrives to a primary stroke center to be evaluated, and processed and then transferred out to the thrombectomy center for final treatment. And the goal is to do this in less than an hour. And then the earlier treatment time, which is something that has been explored with the mobile stroke units, which are ambulances that are equipped with CT scanners that allow the doctors to, via a remote connection, give TPA faster. And very fast treatments from onset of symptoms to IV TPA infusion of less than 30 minutes have been reported with these mobile stroke units. These are the results of a registry where patients that needed thrombectomy were evaluated in terms of times for different points in the process of evaluation and treatment, comparing secondary transfer patients to direct transfer patients. And as you can see in the slide, patients that were directly taken to the hospital where they could get thrombectomy took 229 minutes from the onset of the alarm to the thrombectomy. And the patients that had to arrive to a previous hospital and then transferred secondarily to the thrombectomy center took 311.5 minutes to get there. So if we consider that functional independence, the chances of functional independence decreases by 5.5% per hour from the alarm to puncture, we definitely have a significant case to make that taking patients that need thrombectomy directly to the center that can do it, it's beneficial. And with this modeling of based on this paper, what they determined was that if you bypassed a primary stroke center to get the patient to a thrombectomy center, that would delay IV TPA by 12 minutes. Most patients would not miss the TPA window, and mechanical thrombectomy, which is the definitive treatment, would occur 91 minutes earlier. Again, if you factor in a decrease in chances for independent outcome of 5.5% per hour, that would be a 12.5% drop if you weren't able to get the patient within 90 minutes, as the modeling suggested. If you bypassed limited to 20 miles, then it would be 7 minutes delayed for TPA, but mechanical thrombectomy could be done 94 minutes early, a big gain. So we did a pilot study in Baltimore City where we defined a protocol to take the patient directly to the thrombectomy center. And as you can see here in this slide, we take the patient directly as opposed to first taking them to the primary care hospital and then secondary transferring to the thrombectomy center. This was based on the severity-based stroke triage algorithm that was put out by the American Heart Association in 2017, and was based also in the organization of the Maryland Institute for Emergency Medical Systems and Services, since 2009 has been developing the routing strategy for the ambulances for acute stroke. First, mandating that patients with acute stroke within 2 hours of onset had to be taken to a primary stroke center, then adding that if they were within 3.5 hours of onset, they had to be taken to a hospital, a stroke center that was able to give TPA up to 4.5 hours. And then in 2016, instituting a clinical severity score, the LAM score, which I'm going to mention a little bit in the next slide, to then decide which patients could be transferred directly for a thrombectomy center based on their severity. And this is, again, a representation of the incremental change in the Maryland transfer guidelines to facilitate stroke patients getting the right care at the right time. So there are several scores and scales for acute stroke. The most common or most well-known is the Cincinnati Stroke Scale, which is similar to FAST, is the phase arm and speech and time scale, the Los Angeles pre-hospital screen, which is very, very similar. And then there's the more complex stroke scores like the NIA stroke scale, which is usually preferred by physicians. But there are the Los Angeles motor scale, which is very simple, and it consists here, you can see in the slide, facial droop, arm drift, and grip strength. And the LAM score, as well as other scales like the RAISE scale, the 3-item stroke scale, correlates with the severity and also predicts the probability that the patient have a large artery occlusion. So with a LAM score, a score of 4 or higher has a sensitivity of 81% and a specificity of 89% to detect large artery occlusion, with an overall accuracy of 85%. So with the LAM score adopted as our pre-hospital scale, the ambulance personnel would do a Cincinnati score first. If it was a stroke, then they would do a LAM score. If it was more than 4 points, then they would bypass primary stroke centers and take them directly to the comprehensive stroke center. So what ended up happening is that patients were diverted. 22% of the patients were diverted to a comprehensive stroke center. And the diverted patients, interestingly, half of them had ischemic stroke, but there was an extra quarter of patients that had intracerebral hemorrhage, which is normally a condition that causes a secondary transfer as well. So in essence, 45% of the patients that were diverted to a comprehensive stroke center were patients that would have normally been secondary transfer to those centers. Among the ischemic strokes patients that were transferred, half of them had an intervention. So a third of them a third of that half had IVTPA, a third had thrombectomy, and a third had both IVTPA and thrombectomy. So the pilot showed that there was possible to select the patients in the field, and also showed that it was feasible to transfer them to the thrombectomy center, and that this was worth it because 45% of the patients would be patients that needed to be transferred, and half of the patients were ischemic stroke, and half of them would actually have an intervention. So we decided to do another study last year, which is underway now, in which we expanded the area of triage from just Baltimore City to a 30-minute travel time radius. And we're currently evaluating the effects of that. Now, the tools for stroke detection once you get to the hospital are also the same. Cincinnati Stroke Scale, BFAST, which adds the posterior circulation symptoms, with B standing for balance, E for eye abnormalities, for example, eye movements, double vision, loss of vision, F for face, A for arm, S for speech, and T for time. And what we recommend is that an emergency department should pick a screening tool to detect patients with stroke at triage, and that facilitates and makes much faster the activation of acute stroke services. So one has to design the way that you're going to evaluate these patients, and as you see in this slide, first is the detection of the patient at triage with a scale, BFAST or Cincinnati or FAST, assessment of the last known well. You always have to make sure that there's a airway breathing circulation. And then you have to have a strategy for selection. So if the patient is last known well is 0 to 4.5 hours, those patients can get thrombolysis, and the LVOs, the large vessel occlusion, can get thrombectomy. They might need a CT scan only if the NIA stroke scale is less than 6, or they might need a CT scan plus CTA at the beginning as the first evaluation if the NIA stroke scale is equal or more than 6. Some centers do a CT scan for all, and then as a secondary test, they do the CT angiogram. In the 4.5 to 24-hour window, again, if the patient is likely to have a large arterial occlusion by in a stroke scale or LAMS, it might be faster to do the CT, CTA, CTP, which is what's going to be needed to make the decision, and to do that early so that the patient doesn't have any time wasted in terms of developing terminating a treatment. And to conclude, for stroke, developing pre-hospital systems is as important as in-hospital protocols for best outcomes. The key is detection and routing protocols, and the goal is to get the patient to the right place at the right time. Thank you very much. I hope that this is helpful and that you have enjoyed this talk.